We're going to get started. Thank you all for coming so early this time of year. We appreciate it, and at least we beat the snow that's going to come this weekend, hopefully, right? Yes. I'm Jan Rutherford. I'm the Chief Commercial Officer here at 3T Systems, and on behalf of everyone on our team, we welcome you today. This is our fourth Healthcare Executive Forum we've done since June, and every turnout has been better and better. I guess this is the only open seats in the house today. So again, thank you for coming. And just so you know, some of you might not know who 3T Systems is. We're a complete IT services company focused on consulting, managed services, and cloud hosting. We're down in the tech center. We've been around for over a decade, and we were doing cloud hosting before it was called cloud. And most of our interest in business is in the healthcare vertical, so that's why we want to assemble this group and really get the conversation going and get all the right people in the room. And what we like to say is that we want to provide companies, organizations the freedom to focus on their core business, which in healthcare is taking care of patients. And that's and then we want to take care of the IT side of things. So that's what we're all about. Some of you may have read in a press release that we recently merged with QSE and joined forces. And Marion Jenkins, we're really glad to have him and his team on board. Marion, can you stand up? So, and just a quick story. Marion talked to us on October 2nd. We had our last healthcare forum on the 3rd. Marion showed up because we were in discussions. Our team was saying, why is the competitor here? And 27 days later, we did the deal. So we moved pretty quick, and we're really glad to have that team on board. So let me just see who's in the audience. How many of you have been at all 4 of our forums since June? Anybody? Nobody. Okay. How many in here are at the C level in your organization? CEO, C level? Okay. How many on the provider side? Okay, payer side? Technology. I'm looking at Jim. Okay, good. We got a really, really good mix. And I know a lot of you were able to meet and talk to each other at the very beginning. And what we found is at the end, we will end precisely at 9 o'clock, I promise, that probably half the room kind of stays around for another half hour and exchanges business cards and things like that. So we're always happy to see that happen. Also, I'd like to thank Elise Mecchio, who really put all this together and did all the logistics. And she's our marketing manager. And then if I could get all the 3T folks in the room to stand up just so you know who they are, that would be great. So this is a gang. And of course, we have people back keeping the blinking lights on right now, too. And, of course, we'd be remiss if we didn't thank a couple of our key partners, Yvonne from Citrix in the back. Thank you for putting this together. And Sharon and Mike from Del Weiss also. Thank you. The other thing is, I know you all saw Holly and Elise going around polling, and we do have a Twitter feed going, and that is hashtag 3T Healthcare. So we'll be monitoring that. If you want to put questions on that instead of raising your hand, you can do that. And our handle, if you will, is at 3T Systems IT. And that's, we'd love for you to follow us on Twitter. So in the poll that went around, they were basically asking the questions that we as moderators want to talk about. And no surprise, what came up is the topic of most interest was interoperability. And that was followed by security and liquidity. So it'll be interesting. It'll help Jake and I moderate this panel, and appreciate your input. And at this point, let me introduce my co-moderator. For those of you that have been at some of our events in the past, it was all me. And I'm really glad to have Jake Hughes, our CTO, join me. He was at our last meeting, and he just joined our company about 6 weeks ago from Seattle Children's, where he did a lot of great work with Citrix and Cisco, and he understands healthcare and he understands IT, and we're thrilled to have him. So.
Thank you.
So So to introduce our panel, we've got Hans Wiik from IPN and IPA, located mainly in the north. And Hans has a whole bunch of alphabets after his name. He's a pharmacist, and he has a master's in public health and public administration. And my understanding is you were one of the first to develop a clinically integrated network with your physicians. And you've been a CEO of hospitals in the Northwest, and you've been around and been there, done that, seen that.
Older than dirt.
Older than dirt. So we're really happy to have you here, Hans. And we have Phil Kalin from CIVHC. And some of you may know Phil. He's been there 3 years, and before that he was CEO at Rose, and he was a senior administrator at Henry Ford, and avid cyclist. So of course I got to put that in there too. And a snowboarder. Okay. What else does Phil do? You probably are realizing that Kelly is not Larry Wolk from CORHIO. Kelly is joining us because Larry wasn't able to come at the last minute, and he sends his regrets. He was at our last panel, and Kelly heads up the Health Information Exchange program operations, or operations program operations, and a master's in information systems from good old CU Boulder, right? And lastly, we have Nick Knowlton from Greenway, who's the director of Strategic Initiatives. And he's from this little school called Notre Dame, and a biochem major. And we were just talking about who's going to win. I'm not going to tell you what he said. Yeah. So again, Nick, we appreciate you being here. So without further ado, I want to kind of get things started, and then I'm going to really let Jake run with moderating, and I'm going to float around the audience. And what we really want is a lot of participation from you. So if you see me kind of wandering around and you have a question, flag me down. We want your questions to take precedent over, what we're trying to do to guide this. So what we've said to the panel is the only question we guarantee that we're going to ask is the first one. Okay? So again, keeping in mind that you already have a preview of the sort of questions that we want to ask based on the poll that was conducted. But the first question really has to do with the foundational elements of interoperability and data liquidity. And from a starting point, what's a must from your organizational perspective? And we'd like to start by hearing from Hans and Nick, really from the EMR side of things. So Hans, could you take a stab at first? Sure. And that mic's in, Nick's got the mic he needs to share with you.
All right. Sound check, everything's fine, good. So we have a lot of IT folks in the audience, and we have some providers, but let me just talk a little bit about the importance of data for us, because we're at the downstream end of why data is important, because it's at our clinician level, and in our 200 multi-specialty provider group, 150 of which are primary care, having actionable decision support data to drive performance improvement and quality and efficiency is critically important. So to my left, I've got a lot of people who are instrumental to making sure that we have actionable, validated data that helps us drive our performance. So Phil collects it from the claim side, which is important because on a longitudinal basis, I need to know if we're driving value based on the work and quality we do, because in the absence of that, I don't know whether it's an employer group or insurance group or attribution that I can drive that performance. From Kelly's perspective, as she helps collect data from any disparate number of different providers, we have a number of interfaces, 23 ourselves on our EMR. But even in that, I need data when people travel, when they're in the hospital, data in terms of different provider groups that allows us to know exactly from a fairly detailed perspective what's going on with those patients that we have impaneled in terms of population health. And then, of course, our EMR, and Nick here is with Gateway. And EMR is just critical. It's foundational in terms of the fact that it allows us to get that validated systemic data and to keep our practitioners productive in an EMR that allows us at that practice level and provider level to collect validated data. So we have a couple of cliches in our organization that...
Hans, can you put the mic a little closer? There
Okay, a little closer.
For the back, thank you.
That is important about that, because I'm at both the front end and the back end of data. And what I mean by that is data is, as we know, garbage in, garbage out, or it's gold in or gold out. And we really work hard on the systematic input of validated clinical data at the provider level with quality coaches and others. Because in the absence of that, then I don't have data that comes out on the other end that allows me to understand what's going on with our patients. So having an EMR tool with the right templates that collect, one simple example, if a diabetic comes into any of our practices and we have 8,000 diabetics that I can slice and dice data on, I need to know that every provider, every MA opens up that diabetic flow sheet, enters all that data, and I mean structured data, not somebody using Dragon Naturally Speaking, because that's not data. That's just text. And we have to have that data, and we have to be really careful so that when we get that data in, data's validated. Our doctors own the data because it's their data. But if it's just text, it's not data. So we spend a lot of time. We say in our cliche that of the equation, 10% is software, but 90% of it is human and culture. And so we're really focused on that. And then on the other end, it's the output of that data, because in that output of the data, then it allows me to produce registries, risk adjust all of our diabetics, drive to performance in terms of understanding who are high-risk diabetics, our high-risk heart disease patients, and making sure they stay out of that expensive place we call hospitals. So that's literally what our organization is all about in terms of the fact interoperability is important and the liquidity, but we still have to have validated data that our physicians can use at their practice level and at their team level to drive performance.
And Hans, so what I'm hearing is you're saying the data is critical, but also foundational. One of the key components is the EMR. Is having an EMR that is able to collect that data and pump it back out, and I think that's a good segue over to Nick. From an EMR standpoint, what do you see as the foundational components that you're building into the Greenway product suite?
Sure. To build on what Hans was saying, I think the first place that you have to start whenever you're laying out, change in an industry and what that means for technology vendors and other stakeholders along that chain is what are you trying to accomplish at the end of the day? And it really gets back to, what Hans was talking about. You hear about the triple aim, you hear about improving population health, controlling costs or taking costs out of the system, and improving the patient experience. Well, a lot of people are doing that with analytics engines these days, and the way we look at it is a chain is as strong as its weakest link. If you don't have data in place for the analytics to run on, your analytics aren't going to be producing anything useful to you. If you don't have data getting to that's point of aggregation, you're not going to have anything useful, and that's where data liquidity and interoperability come in. And at the start of it, it's where physicians enter it. So also to his point about IT being one piece of that solution, we need to evolve a bit as an industry towards not just physicians at the point of care and EMR and their workflow there, but really what's the workflow across the community of care to take care of the at-risk population, to identify patients that need further follow-up or coaching on changing their lifestyle and things like that. And our challenge as an industry is to assemble all these disparate IT vendors to say, all right, this isn't just about what one person is doing with your system, it's about how that interoperates with an at-large ecosystem these days to achieve those ends. So it's not an either-or proposition, it's really an and that's what, the challenges facing this industry are. So from a foundational perspective, we need to make sure that all the vendors that have a stake in this game are committed towards working with others to achieve that end. And the best way that I can describe it is interoperability needs to happen in a scalable, repeatable, and probably to a large extent inexpensive manner. And it has not been an incredibly easy problem to solve for the industry. That's why you see this movement in fits and starts through the meaningful use programs, and you hear about moving from CCD to CCDA, but we're getting there, and we're starting to see a lot of traction between the different vendors. I know I have a few competitors in the audience today, and we actually work very heavily with their companies, in a pre-competitive manner anyway, to make sure that we can do this on behalf of all of our customers.
Excellent. Now, Kelly, I'm going to come back to you in a second. We mentioned triple aim in there. Phil, if you can talk a little bit about triple aim, kind of what foundationally ties in from a triple aim standpoint, and give kind of a little bit of background of what you're looking for, what the foundation you need is.
Morning, everybody. So anybody know triple aim? Better health, better care, and lower costs. And our organization is really focused on what's going to take to achieve that in Colorado. And I think the thing that I would start with, and I don't know who, Hans and I are the two guys, we're just older than dirt. So we've been around, we've seen this for 30 plus years, this kind of things need to work better, interoperability. But the thing that I would start with is to say we are out of money. As a country, we are out of money. So all the conversations we're having today about interoperability and all the things we need to change, there's nothing that focuses the mind more when you're out of money. And I would say to you that unless we get our act together and figure this stuff out, that we're going to move very rapidly toward a single payer system 10 years out. So for all of us business development people, business people, I think we got to get real focused real fast. And from our standpoint, if we're going to achieve triple aim, better health, better care, and lower the costs, then we are going to have to take a very, very hard look at how the data is flowing together. We're responsible for an all-payer claims database. So as Hans mentioned, we are bringing in all the claims data, and we are going to be making it public to show how people are performing on cost, quality, volume, et cetera. So if you're a hospital provider, if you're a clinician, all of your data is going to be out there. So there's going to be full transparency, number one. So, and businesses are going to be taking their business, their patients, their population, and they're going to be directing it toward the best value. So all of that is going to be going on, and it is going to, I think, focus the mind of many people of saying that we cannot have any more this waste going through the system. Right now, we know we have 25% of all that we do is wasted. It's been documented 100 different ways. So as I look and as we look at what's going on in the world right now, many of you probably saw in the Denver Post a couple weekends ago that the Walmarts, Boeings of the world, they're essentially taking their hips, knees, and they're sending them off to the Cleveland Clinic. They're sending them off to, some of them are sending them off to the Philippines. Geography doesn't matter. They're looking for value. I'm holding my hand an article I just picked up. There's a couple companies called Virtual and Zipnosis. These companies are out there. They're providing services when you want it, when you need it, how you want it, online, through teleconference. You don't need to wait in a doctor's office. You don't need to go through all the hassle that our current system has. So the message that I've got is we have got to squeeze money out of the system. We have tremendous waste, and that the transformation in terms of how data needs to move, the ability to integrate the claims data, the clinical data that we're talking, is going to so overtake the conversations that we're having now that it's going to make your head spin. And when you start thinking about, the last thing I'll say is there's another article I was looking at with Medtronic is pumping out data on heart devices right now that are going out to Medtronic, but it needs to be getting into the medical record. This Zipnosis stuff that you're seeing, that needs to be getting into the medical record. So I think we need to not only elevate our game in terms of the interoperability conversation we're talking about in the classic structure of how healthcare is provided, but if we are going to prevent going to a single payer system, which then is the next step down to single EMRs and all the rest of that kind of stuff, I think we better pay attention to this, do it real fast, or else the marketplace is not going to be recognizable.
Now, Kelly, we talk about data moving, we talk about the EMRs pumping out this data. You're receiving a lot of this data. Your organization, CORHIO, is pulling a lot of this data in. So Speak a little bit about the foundation, what you're seeing from the players that are pushing information up into you, and from your perspective, receiving that, what is the requirements, what is the basement level stuff that needs to happen?
So from CORHIO's perspective as a health information exchange, you know, we're in the business of moving large volumes of disparate data. So we need that data standardized and normalized. We need to be able to get that data to point of care for immediately, real time, for analytics and for decision making, and we need that data eventually to be you know, meaningful to patients, usable by patients, you know, how they think, how they can use that data. And you know, Nick nailed it. From our perspective, our largest challenge obviously is turning that data into information and getting it into EHRs, getting it at the point of care. And you know, if you've worked with one EHR vendor, you've worked with one EHR vendor. And our cliche, or our analogy at CORHIO is, you know, this is like underwater synchronized ballet. You know, when you get ready to go into a practice to integrate and to provide this data to a practice via their EHR, you know, we, CORHIO, have to be ready from a time and cost and technology perspective. Our technology vendor, Medicity, has to be ready. The EHR vendor has to be ready, and the practice has to be ready. And so what ends up happening, because we lack this interoperability, this is new, this is hard, everybody does it differently, is the providers end up spending a lot of time testing, working with us, and that's not their day jobs. We're taking them away from their day jobs. So the importance from our perspective is exactly what we've been saying up here. That interoperability has to happen quickly, not only to keep us from going, you know, keeping us away from a one-payer system, but giving folks what they need when they need it.
Absolutely, absolutely. Now I want to pause here for a second. We've covered a lot of ground in this kind of opening topic. Jan, do we have any questions from the audience on anything that we've covered at this point?
Anything so far? Okay, I think let's proceed.
All right, we'll keep going.
And again, just flag me down if you have any questions.
So there is one area that I'd like to start to hone in on a little bit, and that is security. We talked a little bit about it before the forum began, but security is paramount to the clinical environment, to the healthcare environment. And the hospitals and the practices are doing security relatively well in varying degrees within their own organization. But we've got this evolution into securing the data as it leaves the walls and changing from securing large data sets as an individual chunk to securing down to the attribute level. So I'll open it up to the panel, whoever wants to jump in first. What are kind of the challenges that you're seeing? What are the measures of security that are missing or that you can highlight that are doing well right now?
Well, I have one interesting perspective on the security thing, because we've been talking about that for a long time. The interesting part is that if you go out and ask 100 people on the street now what they know about where their clinical data is being shared, they're not even knowledgeable to that. If you ask them, would it be okay if we share all of your clinical information through a data exchange or through other providers or through other people in your insurance industry and claim, most of them would say, I didn't even know that was being shared. And actually, it's when they sign that privacy agreement at any provider, immediately those rights are almost there, because it's in the processing of that claim. What's unique about us is that we figured out in our multi-specialty group that we wanted one EMR and one common medical record. And as a result, that opened up that record among all of our providers. So when our primary care refers to our neurosurgeon, cardiologist, general surgeon, orthopedic, it is one medical record. That's great for coordination of care, of eliminating duplication of services, because they have all the medications, all the history, all the allergies, all of the complaints, and so everybody's working off the same song sheet. However, in our 160,000 patients, it also opens up the door about who's looking at my record. Now, the irony is that most of us who came from the paper chart days realize that the security in the paper charts days are worse in terms of finding out what happened and who's looking at records inappropriately. Now I got fingerprints all over the place. Somebody opens up a record for the wrong reason, I know it, and I can investigate it. We have one common group security and privacy policy for all of our practices. And in terms of our security, we have auditing tools. We have an IPN security team. We have VIP patients. We audit routinely monthly anybody looking at the charts for the wrong reason, and we bring it to their attention. Now, it's a responsibility of that practice if they find one of their employees looking at a record for the wrong reason, because if there's a wrong reason for looking at it, because immediately they put their fingerprints on opening up that chart, and we have to find out why they did that. Now, if it was by accident, fine. But if it's repeated behaviors, we can quickly say that's wrong, and as we know, there's severe penalties for that. So we now have to communicate to all the patients that as a result, when they come into our practices, they have a common medical record. Try to explain that to a few folks to understand what that means. And at the same time, let them and all of our providers know that this is serious. So all of our practice managers, providers, and employees, those, I think we have about, we have about 1,500 end users. It's very clear to them that they know that we are looking over their shoulders on an electronic way, that if they are absolutely looking into records, it's grounds for termination immediately, because that's just the way the world works. We also require that they have annual HIPAA training and attestation of that annually at every practice. I keep that on file, keeps our premiums down for our privacy. We also attest that they have their absolute maximum encryption standards in place at every practice setting. I don't want somebody telling me they hacked into the office's EMR from the parking lot. Doesn't work. So we've got to make sure we get granular about security, because we are responsible for the security of these patients' medical records. That's our responsibility.
Now, Kelly, as it transitions up and out of the practices and out of the EMRs, how does that translate into security within your organization?
So from our perspective as an HIE, we are following, we must and we do follow all of HIPAA, high-tech, NIST security standards. As participant in CORHIO, when you sign your participant agreement, you are following those standards as well. You are committed to doing that. We have a statewide policy committee that we run that dictates anything above and beyond state and federal laws for how the data is going to be used. We're talking both about privacy and security. So today, today it's challenging enough. Han said it. Try explaining this to the consumer, to the patient. Today it's challenging enough because from a privacy perspective, it's binary. You're opted in to the HIE, and I'll explain what that is in a minute, unless you request to opt out. It's very difficult to explain that you're not opting out of having your data transmitted. We still need to do that. We still need to do that just as that's done with fax, with courier. You're opting out of, allowing those participating in your healthcare to see that longitudinal view of your data. And people don't realize that difference. It's complex, it's hard to explain, and in a lot of cases, people have no idea that's not already happening. So that education is so important. It's important now, and I can't even imagine when we get down to privacy and security at a more granular level, instead of it being binary, without that level of consumer and patient education, that's going to be more and more difficult to do.
Absolutely. Phil and Nick, anything to add on the security front?
Yeah, just a couple other perspectives. So with the all-payer database and as it relates to the HIE, one of our challenges is if we're going to look at cost, quality, value, we need to be able to link up saying here's what was done with the patient, here's the procedure, here are the diagnoses, et cetera. And what we really need to do is be able to link that up through some kind of unique identifier, protecting privacy and security, to understand what is exactly happening, so you understand what are the outcomes. So I can tell you what it cost, I can tell you how many procedures were done, certain diagnoses that went in, et cetera, can give you all kinds of performance. But at the end of the day, until we can link up with the HIE and know exactly what the final outcome is, is the patient better? Do they have full functioning if they had their knee done, et cetera? So that becomes a challenge. So one of the things that we talk a lot with the HIE about is how do we longitudinally connect up, so the 4 million covered lives we're going to have in our system, how do we match them up with an HIE so that you can truly get, if you're managing an entire population, a true picture of what's going on. The other interesting challenge, and that I think we just need to be much more open with our discussions with consumers, is it is a double-edged sword. I mean, you want the kind of collaboration and integration, interoperability, and identification that we are all talking about. You don't want this stuff splattered out where somebody is able to hack into it. But we've got to figure out ways so that we can talk, But also the other interesting piece that has to be figured out is how do the patients get access to this as well. So we can build all the security, and then the patients, they want, Todd Park, who's the Chief Technology Officer of the United States, talks about the blue button thing, where they are allowing people that were in the government system, the VA system, to literally go get all their medical records. The one article I was alluding to with Medtronic and monitoring the heart devices, they're saying, well, we can only give the information to Medtronic and to the doctor. You can't see it as a patient. So it's really an interesting balancing act that we have to achieve about maintaining security, but also if we're going to engage patients and others into the process of changing the trajectory of healthcare, that we're going to have to find ways to do this and have an educated conversation about it.
Absolutely, absolutely. And this is very contextual, Nick, to what your organization struggles with, I'm sure, which is how does the EMR play into the security mechanisms and to making sure that that data is not only liquid, but also extremely secure?
Sure. We deal with this on so many different levels, from audits that we have to face as an EHR vendor going into, a large deal for an enterprise system. They want to know that they're protected. So we do a lot on that level. From the interoperability standpoint only, though, the interesting thing is people tell me all the time, hey, why is it taking so long to stand this up? Well, you look at us standing up a connection to CORHIO, it probably takes us longer to negotiate the legal paperwork around security, not necessarily with CORHIO, but with other stakeholders in the value chain, for how that data is going to move, who has access to it, and things like that, than it does to do the technology work. So one of the things I think we're going to see is an area where public policy can be very effective. We're going to see a lot of convergent evolution around how those things happen. A lot of organizations are inventing this for the first time for themselves. I had one of the largest hospital chains in the country told me last week that they want to send us every piece of lab data that comes out of their hospital and have us filter for which providers are ours versus which are somebody else's. So you can imagine what our response was to being exposed to that sort of thing. No, we don't want to do it. So back to the earlier comment that you need 2 IT vendors and you need 2 organizations at least to establish interoperability. They all have to be on the same page about security and access and how you're going to do this. The other comment I would make is that a lot of the security issues have a huge impact on workflow. If we're working with an interoperability vendor that wants our providers to be able to log into their portal using single sign-on type technology, those standards are still evolving. There's a bunch of them, from custom API calls to SAML 2.0, and everybody needs to be capable on all of them, or else the industry needs to settle on one. So I think we're going to see some convergent evolution in the standards there too, that not only enable us to maintain that security, but also achieve optimal clinical workflow so that the physicians will actually be inclined to use it.
Right, right. And I want to drive home.
Just real quick, did Michael Torian asked a question via Twitter. Did Nick just answer your question about interoperability in an example? Yes. Okay.
Excellent. How's that for being efficient? I did want to drive one point home, and I think it's a theme. It's something that I believe, and it's a theme that I'm hearing from the panel, and that is technology is not the problem. Technology is not why this is taking so long to take hold. It's the back pressure of politics, it's the back pressure of the red tape that's associated with this, and the processes for getting it done. Is that an accurate statement?
From my perspective, I'd say there's still technology development that needs to be done as an industry. And, we see this every day. I know you see it probably more than I do, the differences between vendors in terms of what they'll support. I know one of the things that we want the panel to talk about today is some of the meaningful use standards, but the original standards for CCD, as an example, were incredibly loose. So there's a lot of interpretation for how you can do this, and all the companies started doing what they thought was the best practice. Well, the companies run into each other because their customers want them to work together, and all of a sudden they find out, hey, you use RxNorm and we use Metastat for coding meds, or you're using SAML 2.0 and we're using custom API call. So there still is technology development that needs to be taken to its next state of evolution. But yes, probably the biggest thing slowing it down is you know, politics, cost, and you know, legal ramifications of what we're trying to do.
Right, right. Now you mentioned one thing. I want to transition a little bit here, and Hans, I'd like to get your perspective on this. Meaningful use. It's very much a part of our day-to-day lives now. We're transitioning between phases as we talk. What is meaningful use from your perspective? How does it tie into interoperability, and what are the challenges that you deal with?
Well, meaningful use, I was even looking at emails last night about that. So as you can imagine, we're all over that. I think as of this last month, with all of our practices attesting, some attesting this last quarter under the 3 core measures, and not even thinking about the brain damage for the stage 2 meaningful use measures, which is going to even drive more of this ability to pull data out of these systems, because that gets harder. And we're also, when we think about data coming out to report to third parties, whether it's CMS or others, then it's also, we have more patient-centered medical home providers than any other organization in Colorado. We have 120. And we have a glide path that every one of our primary care practices will be PCMH Level 3 NCQA certified within 12 or 18 months. The data elements just in PCMH and meeting those standards to maintain their certification is as difficult, if not more difficult, even though the overlap in meaningful use. So I think we've returned close to $2 million now to our providers in attestation on meaningful use. And so we've had to literally create our own clinical data warehouse with our own BI tools to pull our data out of our EMR so we can pull this data efficiently. As Nick can tell you, it's very hard for even the EMRs to pull this data because they're not working at the provider level understanding it. But they have to start thinking about that, because that's basically what they're doing. How do we get data out that makes it easy for us to attest to these requirements on a third-party basis? That's a lot of work. Just to give you an example that scares me a little bit about the cost situation of what we're in and taking cost out, and we have another cliche, many of you hear it, is that remember in this thing that when we're looking at waste in the system, remember that's also somebody else's revenue. They're not letting go of that easily. And so I was in an advisory board meeting in Chicago on Monday, and we were talking about exactly what parts of the elements. And what I'm finding out now is that from my provider level perspective, we're making huge investments in analytics, coaching, care coordination, collating behavioral health, BI tools, analytics. I'm duplicating tons of functions that the insurance companies have historically been doing, but I'm not getting paid for it. And we need to understand that if the providers are going to do this and drive costs out of the system, as Phil has said, and we create value, then I've got to get part of that premium dollar to pay for this new infrastructure that's being required of the providers. Because if you're a standalone small practice and somebody told you that you had to pull all of this data out for meaningful use, PCMH, analytics, third party, new shared savings models, you know, actuarial calculations of whether you're going to be successful under new contracting models, they're not equipped to pull this type of data out. And so I say to practices, you're either going to have to, unfortunately, some are becoming employed by hospitals, or they have to join progressive groups like I think we are that can help them be successful. Because my message is that I can't find a small practice who has an IT department, has a quality department, and a contracting department. And that's what we're becoming. We're the whole back office for practices to help them thrive and be successful as independent medical practices.
Certainly. Now I know that we've got some questions from the audience that I want to get to, but I wanted to give you an opportunity to add a little bit to the meaningful use discussion.
Yeah, the piece I would add to that is it's really kind of an interesting situation we're in. You know, right now, all of what we're talking about is being driven in an environment where it's a fee-for-service system. So the more you do, the more you get paid. Well, it changes dramatically when you go to an outcome-based reimbursement system where you're being paid, and ultimately we're at Civic, we're pushing, we think people should be paid for managing a population, getting paid on some kind of global rate for taking care of a population, and all of a sudden it changes the whole equation. And for people like Hans and others, all of a sudden, all of the things that they spend a lot of time doing, those become costs, and the incentive changes dramatically. So they are going to be looking for opportunities to to improve the value chain, to squeeze out cost. And you know, when you think about meaningful use, so the government's telling us you've got to use the data to improve care, to make sure that you're managing quality. Try to translate that into any other business that we know. UPS, Boeing, Toyota. Does the government have to tell you that you've got to start using data to improve the value chain? That's craziness. So part of what we think we have to be doing is we've got to push as quickly as we can to say, we're going to pay you to take care of a population. You're going to get X amount of dollars per month on some kind of severity adjusted basis. So the notion of the government having to tell you, and I understand why in the world we're in, they're putting money out, but we've got to get beyond so that you don't have to put a gun to somebody's head and say, you got to start using this in meaningful ways. We have got to, as an industry, be looking at saying, how do we look at the entire chain of going from the time of diagnosis to the end of services, and how do we keep people healthy so that we are all incented to have the interoperability that we're talking about, so that we're using this data that we're talking about here, plus when we think of big data, you know, how are we putting all these pieces together, and how are we all incented to really understand what's driving care, what's driving illness. And so from our perspective, we're going to be pushing like hell to change the way payment happens so that people like Hans are being rewarded for doing the kind of work that he is doing. And the EMR providers and companies out there, again, everybody's got the same incentive to make sure that data is liquid, that it's flowing, it's getting to the right place at the right time in the right way, so that it's intelligence, not just a bunch of data.
Right, right. Now let's go to some audience questions. If you can identify who you are, who you're with, and who you're directing the question to.
Yeah, and just a real quick comment. Jake, you were talking about the back pressure. Had the opportunity last week to speak to a CEO of a big hospital system in Chicago, and he was talking about his biggest challenge isn't coming up with the strategy and technology. It was figuring out how do I communicate strategy and vision and values to an organization where I've got employees and I have physicians that aren't employed. And so, you know, the strategy was, well, I'll just buy up the practices and their employees and they'll do what they're told. So it's interesting in what the challenges are as you describe as back pressure. So our question is going to be from Phil McCready, who heads up the South Denver Metro Alliance, who's working hard to create a digital health corridor right here in the metro area. Phil?
Thank you so much, Jan. Yeah, I've got a question that really addresses this back pressure issue. In a sense, it's about achieving a breakthrough in the state in this area. So to achieve the breakthrough goals of the triple aim, can the panel suggest either some defined goals for the triple aim? In other words, that seems pretty vague term for anyone to really get behind. What does that mean? Or is there a killer app or policy that could really make a difference?
Well, just like Phil, our organization is also founded on the triple aim, and we actually have an annual quality work plan that drives off that model. So most of us know in our country, when you think about clinical outcomes, better patient care, and a better patient experience, all of us would want that for us and our family, and we all want to lower costs because we all know it's unsustainable. When an average premium for a family is over $15,000, we know we've got a problem. People can't afford health care. We have less employer-provided insurance. So we've got to have goals and aims in all of those areas, and you'll see triple aim on our website. If you want to go, ours is www.ipn.org, and it has all of our accountability and sustainability and vision, and we really drive hard in the weeds about how we performance. So let's talk about clinical outcomes quickly. 75% of our costs are chronic diseases. I mean, that's clear. We're in an aging society. We've got problems in diabetes. It's a pandemic in many parts of the country. We're a lean state, but let me tell you, we're growing in obesity and diabetes in Colorado as well. Leads to heart disease, end-stage renal failure, you name it, it has complications. We have heart disease, we have asthma, we have COPD, we have emphysema, we have back pain, we have depression. Most people with chronic diseases have behavioral health issues. We got lots of stuff and work to do. So we have work plans in diabetes, we have measures. I have 5 years of performance improvement for our 8,000 diabetics. I can show performance improvement by provider, by practice in minutes, showing their clinical outcomes and quality boards in each practice, reducing their hemoglobin A1Cs and putting them into group visits. We also have to think about how we change our whole model of delivery. We built the model of this system on taking care of people in an office setting. We've got to figure out, if we're going to do population health, how to take care of people at home. And that means we have to use new technology and telehealth and reaching out. We're doing home site visits to high-risk patients to make sure we understand the social and environmental barriers that have nothing to do with their clinical outcomes. It's transportation, it's ability to afford meds, they're out of work. It's a ton of issues that have nothing to do with the clinical measures that you see in an EMR chart. So we've got a lot of work to do in terms of taking cost out and getting people engaged in terms of good patient outcomes and high-risk identification of patients, so we know that our job is to prevent people from entering the system if we can keep them well in an aging society with chronic diseases, whether they're genetic or a lot of them are behavioral. And then when you talk about the patient experience, I mean, how many of you call a doctor's office on Monday morning and you're a working mom and you got 2 kids and you got to change your appointment and you're gone on hold, or you just hang up because you can't even get through? So we put in a patient portal, and a patient portal is important. How easy it is to do an email, what a crowd pleaser that is to say to the practice, I got a sick child, I can't make the appointment, can you change my appointment to tomorrow afternoon, rather than say, well, let me go talk to the provider of the MA, I'll get back with you, even if you get through. But now you do an email and you get a response when you're at work and they say, fine, we've got you at 4. We have open access, extended hours. We have open appointments every day because that's patient-centered medical home. So we've got to improve the patient experience. Give them tools and support to keep them well. And we have a common patient satisfaction survey for every provider. We do it annually. We make sure that each practice and provider knows exactly. But the problem with patient satisfaction is that in most of us, and I'll just show of hands here, how many of you here have a primary care physician? How many don't? There's a problem there. And the problem is that we're going back to the days that a lot of people don't understand the importance of a PCMH in terms of patients having a primary care physician. When we do health fairs for employers, and we do this a lot for the employers up in my area, you know who the people who come to the health fairs are? They're the healthiest of the workforce. The people that we're worried about aren't coming. And so I've done diabetic screenings, I've done high blood pressure screening, and we get them back and we find pre-diabetics and hypertensives, but there's no primary care physician. Who's the quarterback? We've got to educate people and the employers in benefit design so that we have people that are identified to help us manage care. And you know, we've got to go back to having people on their insurance card select a primary care physician, because it's all about how do we keep people healthy rather than just waiting and episodically and then just going to the doctor. Because I can also assure you that every one of you in this audience take better care of your cars, your dogs get 2 shots a year, your teeth get cleaned twice a year, but most of you are behind in your own physical exams. It's just because that's the way we're hardwired. We don't have a little monitor or dashboard inside our coat saying, oh, I think I'm about 2 weeks behind on my flu shot or whatever else. So that's the patient experience, that we've got to engage patients and their families, because satisfaction before was just you measuring your satisfaction in your last provider visit. Now it's your relationship to the practice, the front office, the back office. Are they giving you tasking and alerts? Are you in there for your preventive measures, your mammograms, your prostate screening, your colonoscopies? All of those things are important, because if we don't catch it up front, then we've got higher cost on the end. So it is all about getting into the weeds on having action plans on clinical outcomes, which is better performance improvement, better patient experience, and then cost. That's why I need Phil. I need to have the longitudinal claims data by employers. 50% of the health care in this state is just large self-funded employers. They're paying the freight. We're working with employers to say, how do we look to see if I'm actually decreasing the cost and having a healthier workforce? It's absenteeism too, not just the fact, how many people like to have their employees go out and spend a half a day at a doctor's office when they could be working? We got to figure this out.
And Hans, I think you make a very good point, and that is everything, all of the KPIs that you're talking about have to do with this data, being liquid, being interoperable, and getting it up and out of the systems. We were talking earlier that we sit on it. We sit on this data. Healthcare has been sitting on it for years, not doing much with it. A lot of what we're talking about is getting it up and out. Now, I believe we've got another question from the audience that we'll get in.
Mike Campo, Colorado Medical Study. Questions for Phil. How, if at all, do you see the claims database being a tool for identifying Medicare fraud and abuse?
One of the ways that an all-payer database can start to do that is part of what we'll be doing, and it actually fits very nicely with Hans' work as heading up an IPA, is we're going to be able to compare and contrast utilization, costs, and other kinds of metrics, looking across the different providers, whether you're hospital systems, whether you're physician groups, or your individual providers. So one of the things that is going to stick out real fast is where the practice and the volume and the costs start to fall outside the kind of norms that you would expect to see, particularly because we'll be able to severity adjust it, and things are going to stick out like a sore thumb. So that's one of the ways that that's going to help support that.
Excellent, thank you. So one of the areas that I'd like to start to transition to is kind of the future. We've got a good glimpse at the state that we're at now. And one of the problems that we deal with is as we get more and more data up and out of all of these organizations, we're getting massive amounts of data, way more data than any monolithic system can consume and do anything with. This is going to take partnership. This is going to take technology with cloud aggregation, with grid computing. So what is it from a panel standpoint, and anybody jump in here, what is it that we need to do to get to that next stage of evolution where there's so much data up there that we're having to spread it across large systems, a lot of different partners to give access to it?
The key for CORHIO is partnership. You know, I talk a lot about the Health Information Exchange, but as a state designated entity, we are a health information organization, and we cannot get all the data to the folks who need it for analytics alone. So it is work with Civic, it is work with QHN, it is work with public health. It is making sure that those partnerships are maintained, and we find it's the best of breed. Who has the best data? Where is it coming from? And how do we integrate it together to deliver what we need to deliver?
I would add in one more piece, and Phil, it goes back to your question earlier. As we think of, we've got all of this cost, we're out of money, we know we're wasting 25% of it, and one of the things that we need to do is to understand better, going back to Hans' point, is we've got claims data. Let's say we can get claims, we got the EMR data, but we know that we have a lot of people leave the hospital, for example, and get readmitted, you know, within 30 days, 20% or more, and that drives tremendous costs. So one of the big opportunities is if you start thinking about big data and the need for predictive analytics, is to say, how do we understand which part of the population, which patients, for many reasons, socio-demographic, their illness, as they go back out into the community, what are the ones that are going to have a predilection for ending up back in the hospital? Which are the ones that are going to need some different kinds of supports? And when you ask the question about the killer apps, you know, follow the money. You know, Hans gave you the list of the kinds of things that are driving big costs: chronic diseases, readmissions, and those are metrics that we're tracking. So the real challenge is, how do we take the information that we currently have and start to put it with the kind of data out there that the big data companies are putting together, so we can really start to do good predictive analysis and provide patients, providers, and others with kind of information they know to actually start to achieve the triple aim.
Yeah, I would just add a couple things there. our job as an EHR vendor is to make sure that this stuff is liquid and available to the right people. So when you talk about, is it better to have a, central point of aggregation or a federated model or a hybrid model, the question always comes back to what are we trying to accomplish and what are the community dynamics. To, I guess, sort of mirror your earlier comment, we look at it as if we've seen one HIE, we've seen one HIE. You all have different sustainability models, you all have different value propositions to the community, and you all have different technology stacks. Some vendors only do federated exchange, some vendors want to aggregate everything and offer portal views. So I wouldn't say that there's one solution out there right now. We're still in a period of evolution where these best practices are going to be baked out over the next several years. Direct is really only getting off the ground. What effect is that going to have on large structured HIEs? I really like CORHIO's sustainability model, especially now. There are a lot of HIEs out there that I would term artificial geographical constructs. What are they going to do to enable themselves to survive and be relevant, or is something going to come along that's more efficient to take their place? So whatever mechanism it is, it's getting the right data in the right spot for the least amount of workflow headache and the least amount of cost.
Excellent. And you hit a little bit, and Hans, I'll let you respond to that. I do want to hear from each of the panel members a little bit about what you started to talk about. We've talked about what we should be doing, what we could be doing. I'd like to hone in on at least one example of what's not working, what's happening right now that needs to stop or needs to change to enable this to pick up speed and to continue to progress and evolve into what we need it to become. Hans, sorry for the interruption.
Sounds like another hour discussion. Yeah, I think we all suffer from a little bit of change fatigue, and whether it's the Affordable Care Act and all the intricacies therein, and we also suffer from a little bit of data fatigue. I mean, when you go to a provider and you understand the challenges they face in terms of all the changes in their delivery models and their payment models, we got to be careful that we aren't just boiling the ocean. Let's concentrate on the things that are going to really add value. What's the low-hanging fruit in the system? So we spend our time on trying to identify those key factors that can improve community health. I find it interesting that if you pick up any insurance company vision statement or any hospital vision statement, it says we're here to improve the health of our community. But are we executing to that? And what does that really mean? And if I oftentimes say a great tabletop exercise that even any of you can do is to say, what if somebody gave you 5,000 patients that you were charged to take care of from any socioeconomic background? What would you need in place to keep those people healthy? I mean, it's a great tabletop exercise just to start thinking about that. How many are diabetics? How many are asthmatics? What are the issues that we're going to face? What's their age, generation, gender, all those things that come into play if you had 5,000 patients. Curiously, that's the metric that CMS used if you wanted to become an ACO. But when you look at your own community, it's more than just Medicare. I mean, you got safety net. We're proud of the fact that we have an FQHC that's part of us as a part of a community. They serve 17,000 Medicaid, 25,000 safety net patients. We learn immensely a lot about population health because that's what they're all about. They take care, and so when we have to take care of Medicaid and safety net patients, we're all using the same platform. But we don't want to boil the ocean. So what we concentrate on is when we think about readmits, as Phil says, you think about, high cost imaging, you think about the things that cost a lot of money, and are there other ways to take care of people, then how do we move upstream, work on population health, look at chronic diseases, focus on our diabetic registries, identify high-risk patients, the hot spotting sort of stuff. When I work with the school district, just as one example, and I was in a meeting with him last night, Bob Jameson, who's part of Colorado Business Group on Health, he says, Hans, my spend is about $25–30 million for my health care for my employees. 165 of those patients or employees spend 65% of my dollars. Don't you think we'd like to know what's going on with those 165 people and figure out, I don't want to start working on 3,000. I got to start working on first that 165. What do we know about them? Are they engaged? If they're being managed well, fine. If it's a trauma, fine. But if they've got a chronic disease, then we've got to figure that out. I say the failure in the healthcare system is sometimes pretty easy. Go to any ER log of any hospital, and if anybody's there that has a chronic disease measure, it's a failure of the system.
Thank you, Hans. Now, I do want to give the rest of the panel an opportunity to speak to the topic of what's wrong. And to your point, that is quite a topic. I do want to jump really quick to the audience, make sure that we get audience questions in. So, Jan?
Yep, we've been following some Twitter feeds, and Holly over here has some questions about where the payer is on this panel.
Yeah, I just, our company actually does a lot of work with payers, and so I'm kind of wondering where they are in the room and how you all work with payers, if you work with payers. I certainly see them as part of the discussion, but I'm not seeing or hearing a lot of them, so.
From CORHIO's perspective, payers are an important participant in an HIE, an important part of our sustainability plan. So we are having contractual conversations now with large private public payers. We are having those conversations now. Technologically, we're taking a release from Medicity in first quarter of next year that will enable us to do enrollment and eligibility-based routing. So that combination of getting those signed contracts from the payers and getting our technology where we need it to be will put us in a good position next year to start incorporating payers into the Health Information Exchange in Colorado.
We receive all of our claims data directly from the payers. It doesn't come from the providers, so they're real critical. The other thing I would say about the payers is we engage them a lot in terms of two things. One, trying to move them downstream toward changes in payment mechanisms, and secondly, trying to get more alignment in terms of the metrics, the quality kinds of standards they're using, so that, you know, if you're a physician practice, if you've got 8 major payers, you've got 8 different sets of standards of quality that you got to match. And so part of the work we're doing is going past the payers, trying to get the businesses who, as Hans said, you know, are self-insured, pay for about 50% of the insured care in Colorado, to try to get them to say, damn it, we need to have the same kind of standards that we're using. We need to have uniformity in the kind of the data, the metrics that we're using. And the interesting piece, where all the payers are right now, they're looking at all this stuff going around, and groups like IPN and the Physician Health Partners and the others and the big systems, they are scared to death that there is going to be no reason for them to be around. And they're trying to figure out how do they morph into something where they're more Kaiser-like, you know, in terms of integrated systems. So the extent to which IPN does really, really well managing care, understanding their costs, the ability to understand the risk, it means that the payers, there's less and less need to have a payer to be taking a slice of the pie. And that's one of the interesting balances that we've got going on in our medical market right now.
You know, I'd just like to add that, you know, this conversation that we're having today is very relevant to the payers. We work with them very heavily on behalf of our providers to understand what changes our providers will face so that we can be responsive to their needs. What we're seeing is a big thaw amongst the payers in terms of, you know, being very siloed and saying, you know, we're doing this only our way. We're seeing payers start to adopt standards-based exchange. There are several out there that offer value-based incentive programs, especially for the primary care space, and a prerequisite for participating in those value-based reimbursement models is the ability to share clinical data with them. They like to be able to aggregate that longitudinal record beyond just claims data, and some of the things that they're using some of the evolving industry standards for is even go back to a practice and say, hey, you got a diabetic patient with an A1C and a BMI, they're totally out of control. We're putting in the care plan section of a clinical document back to you that we want you to administer a foot exam for that patient while they're in your office today, because we think doing this you know, across a managed population is going to take cost out of the system. And for that, we're asking you, provider, to send us a bill for a service that you weren't thinking about doing today. So we're starting to see a lot more changes like that amongst the payer community, and we are starting to see them pay a lot more attention to standards-based interoperability instead of you know, just a couple years ago, it was, hey, this is the way we want to exchange data, and everybody better get on board with us. They're realizing that, you know, if you ask every HIT vendor in the space to adopt 65 different ways of doing the same thing, nothing's going to get done. So there's a lot of evolution on that front.
So
I think that's a very good question, and as I talked about change fatigue, and I think also that you have to understand that we suffer from acronym fatigue. And we got so many of the payers, and we do single signature contracts with all the payers. I've got 3 practices in the national CPCI program with Colorado Comprehensive Primary Care Initiative. We signed on as one of the 42 national collaborative accountable care CAC programs with Cigna to drive value for their 8,000 patients in the marketplace. We're sitting down with Anthem, we're doing something with Rocky, we're doing something with United, we have meetings with Humana, I've got another call with Aetna tomorrow, and every one of them has a different siloed approach of how to figure this out. My worst nightmare, I think both Phil and Nick hit it, is that, you know, when a patient comes into a practice, even if you came in a practice, nobody discriminates based on what they're carrying in their wallet. We treat them all the same way. And so we are trying, and you can help me educate the payers as well, to say, take all of our clinical data. I cannot slice and dice by your attribution of your particular insurance, of your quality metrics that vary by each individual contract. We don't have the resources to pull that data, and people move between employers, January 1 and July 1 year. Understand we treat all patients the same way. Our quality data is no different. If you want to slice out all of your Cigna data on all your diabetics and all your asthmatics and have us look at that, then I have to do that for United and Anthem and Medicaid and Medicare. There isn't money in the system to do that effectively, plus you'll drive our providers nuts. I mean, we've got to basically say, let's take care of our patients the way we're instructed, regardless of what they carry in their wallet. People lose their jobs, they lose their insurance. We just need to understand that quality metrics are quality metrics. So we have managed care in terms of Medicaid with Clinica, who's part of us, in terms of understanding how to work with them and driving performance under the new Medicaid construct, because every state's facing a Medicaid budget crisis. So managed care is going to happen in every state, different models, but everybody's trying to get it, and Phil's helping us with the Medicaid data. Medicare, we have some in the ACO program, the Pioneer ACO. You know, we're trying to figure out what our long-term Medicare strategy is. I always worry, though, about negotiating with state or federal government. Sometimes it seems the margins seem to erode over time. I don't know what that's all about, but it doesn't give me comfort level that they're always going to be out there to help us as we're facing the SGR and everything else and the Affordable Care Act and the politics of Washington. Let's remember, as you're all here, healthcare is local, and that's why we're here. We want to help our people in our community, our bus drivers, school teachers, these employers, these people that make a difference in Colorado. And if our pilot's great, then let's replicate it in other places. But I think in terms of working with the payers, Phil's right. Who has grown more market share in this state than anybody else over the last 10 years as insurer? Kaiser? So either we have to understand they've got both the claims data and they've got the quality data. They can actually sit in a room and manage what's going on with their enrolled patients. We are trying to capture and trying to catch up and trying to do that in terms, and Kaiser does produce great value. But we have to understand that the insurers, as Phil says, are now challenged to say, how do we work with high-performing provider networks who are organized, who can deliver value, and structure a collaborative relationship that's a win-win for the patient, the employer, and the providers who are delivering that care. That's a hard construct because that's part of a journey that many of them have not gone before. What you're finding interesting too, in many markets, these insurers are buying practices. Humana's buying practices, Cigna's buying practices, United's, and so they're coming at it from the other side. And so that's creating all sorts of disruption in other markets to say, so what kind of closed system are we going to have? A closed system run by providers, a closed system run by insurance companies, or a co-op, which just opened up in the state of Colorado, whose board is supposed to be patients. Wouldn't that be nice? Any of you follow group health in Seattle? It's a very successful co-op because it's the patients who are on the board of directors.
Excellent, thank you. So I want to be sensitive to time. We've got about 10 minutes, just under 10 minutes left. I want to check one more time, see if we've got any last-minute questions from the audience.
I just thought, Hans, when you said insurance companies are buying practices, DaVita is buying practices.
That's one of them, yeah.
Yeah.
There's a provider who thinks that this is a great, investment, I'd really like to get under the tent of the understanding, does it really make a lot of sense to own providers?
Right.
I mean, hospitals have done this twice. I mean, I'm sitting here saying, will a hospital-centric or a physician-centric model really work in terms of taking cost out of the system? Phil and I have come from that hospital side, and we understand that it's hard. And I'll just give you one simple example to that point. If you would employ a physician, and we're trying to integrate with our employed physicians at Centura, I think they're great docs. They're the right thing to do. But is it about filling beds? Is it about feeding service lines? Is it about, are you going to require that they use expensive hospital imaging versus independent medical imaging that can actually save money? I mean, we really have to get understanding of reforming the system at the level in the weeds of saying, it's about understanding. As the CFO for Centura tells me all the time, Hans, you're doing a great job with your docs, just slow down, you're killing my revenues.
Absolutely. So let's do final statements. Phil, start with you. Just give you the opportunity to have a closing statement, kind of a wrap up, anything that you've observed from today or that you didn't get a chance to get in today for the last few minutes of the forum.
Well, thank you to 3T for putting this together. I think it's been a very interesting discussion in terms of, as we've kind of gone through the whole waterfront of all the different perspectives here. The one that we're coming from that I can't emphasize enough is, as we change payment mechanisms, we think a lot of this stuff starts to sort it out, because all of a sudden, if it's not about revenue, it's about how do I manage population, how do I manage the cost, and if the business community who's paying a lot of the freight starts to say, we are not going to pay for this anymore, we think that's going to create some very, very quick alignment, and the ability to look at all of this data and to understand what's happening to the patient. Frankly, I think we're going to see multiple models come out of this, and as long as we're achieving value, whether it's a co-op, whether it's insurance run like Kaiser, Kaiser, the docs and the insurers, they're together, whether it's the hospitals or it's real strong IPAs, I don't think that's the thing that we should sweat as much. We should sweat and worry about how are people performing and being able to have very transparent and available data so that we can direct our business to those highest performers. And that's going to be where the future is going to go.
I appreciate the opportunity today. Dr. Wolk's absence, being responsible for implementation and operations at CORHIO, they don't let me out of the building very often, so thank you. I think you had asked what wasn't working, and I wanted to kind of weave that in. It's not that it's not working, but we just need to move faster. CORHIO has integrated now with 11 ambulatory EHRs, another 6 or 7 we're in development with, and it's slow going from everyone's side because of that. Multiple vendors, multiple players, and getting us to a place where CORHIO and Medicity and the vendors are partnered, and we're not doing it our way, we're not doing it their way. We are reaching interoperability so that our providers have the data they need when they need it.
Well, I would also like to say thank you for the invitation to be here today. It's an honor to talk with such a high-powered group. From a what could use improvement standpoint, I think that along the lines of convergent evolution on technology, we're going to see some on payment models too. It's not necessarily our job to predict as an EHR vendor what the future is going to hold. It's just to make sure that we know enough about it so we can prepare our providers for it. So regardless of ownership models for where the physicians work, whether they own their own practice or work for an enterprise health system or work for a payer, I think the first thing that has to be aligned is those reimbursement models. And for accountable care and shared risk and things like that, there's still a lot of good work to be done. There's some, misaligned incentives when you say, hey, you got to be in the top 30% of your cohort to reach the bonus money. That disincentivizes people from sharing best practices and helping, driving some of the costs out of the system. I would say that the other thing is there's a lot of misconceptions out there about what this really means and what the difference is from the HMO managed care days. I think the opportunity that we have due to analytics, interoperability, and data in the system in the beginning is the key difference there, that we can work on managing costs and taking it out of the system while at the same time improving our patients' health and improving their satisfaction with the care that they receive.
So I think other thing that we suffer from a little bit, is that word change. And we've also developed a topic in our best practices conversation is that we're not changing anything, but we're piloting everything. Pilot has a softer term so that they can say, well, it may work, it may not, but we're not changing, we're just piloting it, we're just going to see if it works. But I think we are at a fulcrum in our society. We started by the fact that we know that it's not sustainable, and we've got so many different parts, but we've only talked about certain parts, and data is critical to that. But ambulatory care, physician care, and hospital care, about 50–60% of the equation. We haven't talked about pharma. We've talked a little bit about insurance. We haven't talked about end-of-life care, palliative care, skilled nursing care, hospice care. All of these care transitions have tremendous amount of cost and oftentimes poor baton passes. We've got to get data from those systems as well. How many times people in a skilled nursing on a Saturday or Sunday night go back to the hospital because nobody has the data or the ability to coordinate and integrate care in a way. And with end-of-life care costing so much, and not a lot of people understanding the difference between hospice care and palliative care and pain management. I always have fun with audiences talking about pharma. How many, just on the end of this, because it's I always like to see an audience to say, how many here know how much it costs for a person to have Enbrel for rheumatoid arthritis on an annual basis? Total acquisition cost. Anybody want to venture a guess? You're high, but it's $20,000 a year. And our pipeline for these biological drugs is huge. All of these targeted genomic drugs, Humira, Copaxone, Enbrel, our oncology drugs, and I know that's how pharma is replacing their revenue stream from their loss of generics. And I still have not found a magic bullet to figure out how we're going to absorb the cost of pharma. And pharma is a big lobby, and these are great drugs. Some of these drugs, if I had somebody on rheumatoid arthritis, and I know that Phil Nicholson makes some great money on that commercial, but be that as it may, most people don't know what it cost. And we've got to have much more transparency. And I think one of the reasons you're here is that data creates transparency. And we've got to have that. So society, even as you as a patient, Provenge is a drug that's used for end-stage prostate cancer. By clinical trials, stage 3 trials, I think life expectancy probably about 4 months. Annual cost of that drug is $93,000. Now, I'm not so sure that the patient, the provider, and the family is in a process of real transparent, informed consent with all the side effects that they really understand what's being asked of them. And I'm not saying give up hope, but we've got to come up to grips with the cost of some of these technology and pharma and all the pieces of healthcare that we've created all the silos for, and now we're trying to figure it out. And the only way to figure it out is to get the data. And so we can be transparent about that and understand that when you look at the claims data, as I do for some large employers now, I do it for a hospital and I look at it for a big employer, school district, I get all the medical claims, I get all of the pharmacy claims. I can start to see where the focus areas are in terms of how do we take cost out and make sure. The reason that a lot of these employers have had no wage increases is it's all gone to health benefits. And so that's something we're all challenged to do something. And so as you leave today, anything that you can do to stimulate the conversation about a healthier workforce, whether it's behavior or the things we eat or live or how we breathe or how we think about how we even, if some of you don't have a primary care physician, and I know even probably a couple of my sons don't, but let me tell you, I'm going to say, if we want to change this model, let's understand that we have a partnership with our physicians to make sure that we stay healthy. And that care plan they give you when you have deer in the headlights and when they tell you what you're supposed to be doing, take it home and pay attention to it.
Thank you, everyone. Great job with the panel. Next time we're going to have to get a panel that has some passion about what they're doing. Jake did a great job moderating, didn't he? Yep. And I want to thank those of you that participated in the tweets, Holly and Rich and Catherine. Where's Catherine? Ledoux? We got a bunch of tweets from her, so thanks. That really helped, and thanks for your questions. We appreciate it. Also, want to thank again Citrix and Del Weiss. You have surveys on your table. We would greatly appreciate you taking 2 minutes to fill those out and leave those with our staff so we can improve. We're planning another one in March. And then our big plan for next summer is to work with all of you to create a big executive healthcare forum that's citywide, that we can draw in all these entities. My takeaway from all this is, you know, there's great promise and hope with technology, but like Hans and all of you said, I mean, it's all about people, and it's all about change, and it's all about leadership. And what I know is we all need to work together. And it's interesting, you know, back in the day there was a doctor, and then they started specializing. Well, healthcare has gotten that way very much so. I mean, there's so many subspecialties of healthcare and healthcare IT that none of us can do it all alone. So hopefully we can continue to gather and work together and network and meet each other and really leverage each other's strengths so that we can do what's good in this community and for our state. With that, everyone at 3T, we want to wish you very happy holiday season, a safe season, and hopefully you'll be with those that you love and family and friends. And again, on behalf of everyone at 3T, we greatly appreciate your support and coming out so early in the morning. Thank you very much.